Good afternoon, everyone, and welcome to the Baldrige Foundation's Institute for Performance Excellence webinar, What's Next? Stabilizing Operations and Revenue. As a reminder, due to the high number of participants, everyone will be kept on mute during the presentation. If you have questions, submit them to the moderator in the Q&A box located on your control screen. Presenters will answer questions during our panel discussion. Before we get started today, I want to take a moment and recognize all of our great sponsors and special thanks to the members of the Mac Baldrige Society who serve as trustees to the Foundation's Institute for Performance Excellence and our newest Mac Baldrige Society member, Frieza Nichols, a 2010 Malcolm Baldrige National Quality Award recipient from Fort Worth, Texas. Here is today's agenda and featured guests. Our guest presenters include Dr. Roger Spulman, Senior Advisor, Strategy, Leadership, and Innovation, and the co-host of the Baldrige Foundation Leader Dialogue Program. Dr. Darren Fusillo, co-founder and Chief Medical Officer, About HealthCare. And Ben Sawyer, an industry expert with About HealthCare. After their presentation, we will have a few questions from the moderator and some closing remarks. And now I will turn it over to Roger to get us started.
Hello, everybody, and thanks so much for taking a few minutes out of your day to join us for this discussion. And we really wish we could do this in person and have this conversation with you and see each other, but unfortunately we can't. But thanks nonetheless. And also, I don't want to ever miss an opportunity to thank all of you who are working so diligently in these extraordinary circumstances to continue to provide healthcare for our nation. And we have an international audience today, so globally too. So thank you all so much for what you do. We admire you and appreciate you. And the purpose today is to see if we can add a little bit of some answers, find some answers and some calm in what is really a disruptive era. I know that we're all maybe getting a little bit tired about talking about the disruptions that we're seeing around us, but I'd like to just sort of set that stage. You know, maybe the title grabbed you. What's next? We're sort of all looking for what's next, and we'd love to know with some certainty what's next. And maybe we'll talk about some of those things today. I think we will with our panelists. But pardon me. Let me set the stage for what we'd like to accomplish today. First of all, as I said, we'd like to check in on the state of the industry from a number of different perspectives and see what things are going on today that are causing us the greatest challenges. The next thing is maybe we could talk a little bit about some trends and see, is this going to persist? Will this change the way we have to deal with things in healthcare from this point on? Or what will come to an end? And we can move on to the next challenges. And I think that's probably where we'll spend most of our time today. And then finally, we would like to respond to your questions and comments, and we'd be happy to do that. So make sure you do that, add those to the dialogue on the webinar here, and Al Faber will get those questions to us to respond at the end. But we do have some ideas, some case studies, some ideas for you to consider implementing, and maybe some stories if we have time. But that's what we'd like to do today. And it's our hope, as always, that this will be very helpful to you, and that there might be some ideas here that you can take back to your teams and have a robust and productive discussion on these things. So let's first of all talk about headwinds and challenges and workforce disruptions. Well, this is nothing new to any of you that are on the call, I'm sure. But as we think about this situation we've been in recently, most of us, if not all of us, thought it was going to come to an end long before now. We're going on 2 years, and it has caused disruptions we never thought possible. And you all, everyone in the industry, has had to adjust to it and figure out what to do next. And like everything else, like every crisis in healthcare, I've always said that we are at the top of our game. We are the best in a crisis because everyone puts their shoulder to the wheel. We become we help each other. It doesn't matter if you're a physician, a tech, a nurse, everyone carries their weight, carries their load. They try to do whatever they can to help each other and our patients. And so we're good. We're really good in a crisis. Those are the kinds of people that are attracted to this field. But here's the question. What are we going to do when this crisis ends? And it will end. And we're arguably out of the crisis phase and we're into the adaptation phase right now. And we're adapting to what has now become normal and trying to find out how that really will affect us in the future. So staffing shortages, we're using much more contract staffing than we have in the past. There are issues that have come that we've had to deal with, anger management issues. We've had patients, not just staff, being worn down and quitting, leaving because they perhaps had the wherewithal to do so. They said, I can't do it anymore. So they're coming to the end of their patience and their ability to cope. But I've been talking to providers and they are experiencing like never before impatience and even anger on the part of the patients and acting out and what have you. So those have implications that I think we would really like to talk to. And I'd like to, get my co-hosts or my fellow panelists to talk a little bit about what they've seen in that regard and how providers and patients are acting different in very different ways. But so margin pressures is the next thing. We do have sicker patients with higher expenses. But on the other hand, we have said no. We've said stay away to high margin patients that are not necessarily sicker. They're more procedurally oriented. And my question to you all is, are we certain that we're going to get all those patients back? Are they just waiting for us to say it's all clear? You can come back to the health system now. We're happy to see you and take care of your healthcare needs. Or have they found other ways to look for, treatment options and telemedicine and things of that nature? So how do we want to adjust? How must we adjust to those margin pressures? And then operating as one system of care. This is going to drive us to look for more efficiencies as we seek to become much more efficient and become sort of profitable at Medicare rates. So that's sort of the roadmap for us today. And so let's start and drill down a little bit into these headwinds. And before I turn it over just for comments from Darren and Ben, I heard a quote recently that was very interesting to me. It goes like this: most people would rather be miserable than uncomfortable. And that was by Ken Coleman. He's part of the Ramsey organization, Dave Ramsey. But I've been thinking about that a lot lately because there are people who are miserable. And I think that they're, do they want to be miserable? Do they, because it takes very little effort to be miserable. What takes effort is to move into an area of discomfort, to be uncomfortable. And so I'm a little bit hopeful that today we're going to make you uncomfortable enough to take some action. But let's talk about these headwinds and see, the workforce disruption. And Darren and Ben, feel free to jump in here. What have you seen? Darren, practicing physician and working in the ER. Have you seen any of these things? What are patients, what's happening that's different with patients and providers in your view?
Well, first of all, to your comment about people would rather be miserable than uncomfortable, having had 4 teenagers, I think I've experienced that with each one of them. But no, I'm glad you brought this up. It's been unprecedented these times, and actually, in the past couple of months, I've had a personal experience with this with my own father, who was admitted to a hospital local to where he lives in the Los Angeles area, and then needed to be transferred to a big academic medical center to have a cardiac ablation done. And again, unprecedented times. He waited for 17 days in this one hospital, waiting for a bed to open up at the other hospital. Ultimately, they changed their strategy and started contacting other hospitals to see if there was a bed. And when we say a bed, we mean a nurse, right? Somebody to
Yes.
staff the bed so he can be taken care of. So yes, workforce disruptions are not only very evident in my practice as a hospitalist and working in the intensive care unit, getting calls from the ER asking if they can admit a patient when we don't have any beds, and then boarding the patient down in the ER. And how do we balance that transition? How do we balance that care between the needs of a patient who needs to be in an ICU but now is boarding in an ER? How do we alleviate the stress on an ER doctor who's having to call 20, 30, 40 different hospitals to try and transfer her patient out of there to get them to the care they need? How does it affect somebody like my dad who laid around in a bed and had all the complications you can imagine? A DVT in his arm, the sore on the back of his foot, an infiltrated IV, just everything that can happen to a patient who's just waiting to get the procedure done. And then with our nurses, our great nurses who are, to your point, we're in an adaptation phase, but we're in an extended crisis mode where we're opening up to larger nursing to patient ratios, and we're asking people to do more with less. So no wonder those staffing pressures are feeding into the Great Resignation, feeding into a viewpoint of 10 years before we'll be able to meet the nursing demand again. All of these things we see on a daily basis now, and a couple of years ago, we probably would have scoffed at the idea that those things would even exist in community hospitals. Sure, in the big county hospital, yeah, they board people for 3 days in the ER, but we'll never see that here. It's everywhere now. But we adapt and we move forward. So,
Yeah. Thanks, Darren.
And Roger, I would just say that from a tactical standpoint, we've seen different responses among leading health systems, right?
Yeah.
One, in a short-term approach is, where am I going to get the staff? Obviously, there's contracting, which is a high, sticker cost, and also has an impact on the culture of the organization. Some organizations are looking at potentially immigrating nursing resources from other countries. Not unusual in America's history, right? To bring in people during times of changes in workforce dynamics. The coal era was a good example of bringing in a lot of miners and so forth from other countries. So there's those kinds of things that are going on. Others are looking down the road and saying, maybe we need to have a little bit of a different digital front door and figure out how to redirect people to lower levels of care where they could still get high quality, low cost, best care, but it's not going to require an acute admission. And I think the industry as a whole seems to be looking at, how do we de-emphasize the acute care model, which we've been so embedded in pre-pandemic, and leverage telehealth and leverage hospital at home and other kinds of care environments to be able to reduce staffing load in the acute care space while still accommodating patients and their families in care environments where they can get great care.
Great points, Ben. Thank you. Yeah, what I want to do too is to have two lenses. One lens is, what are the trends that we're going to have to deal with long term, and those things that will be with us for a while. And then secondly, when will we begin to start planning for the future? Arguably, we're past the starting point. We should have started planning. If you haven't already, you should definitely be planning for the future. We're in that crisis. As Darren said, thank you. We're in this extended crisis period, which sort of leads us to those trends. What is it that's going to be part of our new normal, our new daily problem set? And this slide that we're looking at right here kind of identifies some of these things: wage increases, recruitment cost is increasing, and our need to recruit, as Ben said, to go offshore and bring people in. I remember that from 20 years ago. and made a trip to the Philippines myself to try and recruit very highly qualified nurses during, U.S. nursing crisis, because they produce enough to export. We weren't stealing resources from another country. But anyway, we're back to that discussion again. And then all these bonuses that we're paying and flexible schedules and things of this nature, are they going to be with us forever? Or are they going to end when this ends? No, it's not. It's going to persist. I think we all agree. These challenges are with us. They will challenge us for long term. And I love your comment, Ben, about trying to plan for different ways. Don't let other people come in and steal our business from us. Niche players in the home care space, in the personal care space, all of these things. I think our health systems, our great health systems in this country and community hospitals need to plant their flag in those areas and say, no, we're going to serve our communities and we're going to serve as much of it as we can. Maybe you're going to have to partner with others, but these problems will not go away. They will not, they're going to be with us for a while. And so let's get uncomfortable and let's start planning for that. We're done with the misery. Let's start planning for the future. So let's go to the next one. The margin pressures, this whole notion of sicker patients. This is a little different. When we talked about sicker patients before, the complexity of the patients, this is a little different, I think. And as a hospitalist, Darren, you see this and the complication rates. Did COVID cause this, or did the comorbidities make them more vulnerable? These are questions that we don't have really solid answers for. All we know is that our length of stay is longer, are partially due to the fact that we don't have appropriate staffing to care for these patients in as timely a manner as we'd like to. And as the length of stay goes up, of course, the cost goes up. The cost of care goes up.
Roger.
Yeah.
Just to interrupt, I think you're touching on some great things, and it's really a multifactorial issue, isn't it? Not only do you have sicker patients with longer lengths of stay, and quite honestly, if you're in a situation where you're in a healthcare organization that can capitalize on the increased business, then alongside that. Obviously, there's greater revenue generated. You want to provide care, and you want your business to be utilized to its maximum capability. But the longer lengths of stay, the difficulty in decompressing as well, and getting patients out the door if they need to go to skilled nursing facilities who are also full, or the ability for care at home to be provided. So yeah, a lot of extra demand. To your point, although we might not be doing elective procedures, there is the COVID demand on top of what the other unexpected demand used to be. And so you still have all of your, STEMIs and strokes and sepsis and everything else that comes into the hospital, and then load up the COVID patients who are oftentimes quite ill on top of that. And increased demand and oftentimes decreasing supply when it comes to staffed beds.
And Roger, sorry.
Go ahead, Ben. No,
I was just going to add, the complexity of patients makes multidisciplinary rounding more complex. It makes discharge planning more complex. It's adding to excess days. So patients are staying longer than their authorized length of stay based upon their presenting condition, which again is, adds to the challenges on the bottom line. And the friction points increase, right? In other words, getting services within the hospital, diagnostics, transitions between units like ICU, down to step down to med surg, et cetera. And also it becomes more acute if you don't have a good post-acute network and that aperture basically wide open so that you don't have those kinds of obstacles at the end. All of that combined with supply chain, which we have identified here in number 2, are a real problem. And I think a couple points that you were making earlier when we were starting the discussion kind of come back to mind now. One is, we do well as a health system responding to crisis, but it's not okay not to to plan ahead, right, and learn from that crisis so that we can understand in whatever the new norm is, how can we get ready for that? So one of the things you mentioned is, in all probability, in the new norm, any fee-for-service structure is going to have to be at Medicare break-even.
Yeah, absolutely.
And Medicare break-even means that the observed to expected ratio of every patient, observed being what actually happened, on patient discharge versus expected, which was authorized, will need to be at a ratio of 1 or less, right, to be able to actually be at Medicare break-even. And that's a challenge pre-pandemic on great days, let alone during the pandemic with staffing challenges and supply chain challenges. So there's some heavy lifting coming, and the winning organizations are going to be those that anticipate that and look at their sub processes, their people, process, and technology, and figure out how to optimize that in readiness for that transition to Medicare break-even on fee-for-service and wider care transitions in a value-based environment to be able to accommodate, again, the access and orchestration across those environments. I think that's going to have a huge impact on this margin pressure solution.
Oh, absolutely. And I recall, a former colleague of mine who's now president of Trinity Health, Mike Slabowski, when he was COO of our company, he would always push Medicare minus 15%. We thought, you're crazy. How can we possibly do that? But that's what it's going to take. So Medicare break even, we won't be in business very long if that's our target. We've got to, find profitability in our systems at Medicare less, minus something. I don't know, 15% is it, but it's not going to be enough. In terms of
and I think the other obvious point, which is showing in these red bar graphs in the Kaufman Hall slide, is that the CARES Act funding has blunted to some extent the impact of all of these disruptions, but that's not going to continue.
It's an anesthetic right now, right?
It is.
We've been sheltered. I think our systems have been sheltered. We got to wake up to the fact that is going away.
Exactly. So everything that people on the call know about and executive leaders know about in terms of prioritized strategic thinking and execution and team alignment and figuring out how to identify root causal factors and waste in processes and all those kinds of things are going to be have to be a part of the next wave to be able to get to a new normal that actually works for a leading health system.
Yeah. Thanks, Ben. I want to move to this operating as one system of care really quickly, and then get back to you, Ben, on some things in terms of what are we going to do? How are we going to respond to this? Because we got to start doing it now. The time for waiting is over. We've got to get busy and get uncomfortable with these things. But as we think about operating as one system of care, look what's happened. Talk about trends. Look what's happened to virtual healthcare. And, prior to the pandemic, I love this, 1% of all medical and behavioral professional office visits could be conducted virtually. Today, it's nearly 38%. Is that 38? 33. Anyway, it's a higher number. I need glasses.
It was 20, it's 25%.
Thank you, Ben. But I need to see an ophthalmologist virtually, perhaps. But that's just one example. And behavioral health, we don't even have time. We'd have to have a whole separate roundtable discussion to talk about behavioral health alone, and the time factor and the cost revenue consumption factor about how to deal with behavioral health. But oh my goodness, we can't ignore it because of what it's doing to young people and the additional. It's like throwing gasoline on an already smoldering fire. It's going to flare up if we don't address these behavioral health issues. So we do have to get back to that, acting as one system, operating as one system, and supporting each other, supporting our patients.
Yeah, so a couple things there, Roger, if I can. One is the audience will notice in the second bullet of number 1 there that without a resilient and sufficient healthcare workforce, being able to operate as one system of care breaks down, right? Because what you have is cultural ingredients that are mixed, right? So the stability that health systems had pre-COVID first was impacted by a lot of nurses that were really experienced retiring. Remember when the volumes went down?
Right.
And then there is this uptick of staffing resources that are not necessarily, they're not particularly loyal to the organization. They're loyal to themselves and wanting to be able to conduct contract work. So all of those things are impacting the culture of care and the ability to staff things effectively. And then the other thing that you pointed out, which is under evolving digital strategies, is because of the explosion of different care environments, the ability to anticipate capacity in those other care environments, right? When we were primarily an acute care model in healthcare, and being able to direct traffic essentially, almost kind of a segmentation or a stratification of admissions based upon need, is problematic because, you know, as most people know, we'll talk more about this later, but as most people know, the way it usually works is you accept a patient and then you figure out later in the bed management system whether you actually have a step bed to accommodate them.
Yeah.
Right. And that could be too late. Like maybe they could have been seen in an outpatient cath lab, right, instead of being admitted for an inpatient procedure, as just an example. So I think this operating as a system of care is a headwind because of all of these factors that we've been talking about.
Darren, I think you wanted to break in there with a comment.
Yeah, you know, it's interesting. It strikes me that it's a very similar transition that the airline industry went through so many years ago when they came out of a period of relying on old ways of doing things, a lot of extra margin. And when those pressures were brought to bear, they were facing not only pressures on their margins, but they were also facing differences in demands for their services. And ultimately, they were also facing a lot of M&A activity that was, going on with acquisitions of different airlines, combining of those companies. And we're seeing the exact same thing going on in the healthcare industry of, larger systems that are the combinations of multiple acquired systems, different cultures coming together with different pressures, different demands being placed on them for their services. And interestingly enough, just like the airline industry had to find a way to be much, much more efficient, get all their seats filled. Of course, the hospitals are filling up now because of the current demand, but that's not going to last forever. They had to find a way to trim the fat. And we're seeing healthcare systems, especially those that are combined from acquisitions, from unfortunately some systems going under and others picking up those facilities and those organizations, now having to find how to operate as a system of one and to load balance and leverage all of their resources in a much, much more efficient way. And to me, that's where things get really exciting. That not everything has to go to your main 800-bed hospital, that you can leverage your brand across the entire organization. You can leverage your resources. And then you're not paying for people to do less. You're not paying for patients to be in a higher, more expensive locations of care. You can make, to the point that Ben used, an access and orchestration strategy that leverages your entire organization as one.
Boy, that brings to mind the concept of, triage, right?
Mm-hmm.
Not just in the emergency department, but for the whole system. And also kind of a concierge type service, just to sorting out, where do I go? Because frankly, people are confused. Patients are confused now. The hospital
providers are confused.
Yeah, true. Yeah. For years we've been saying, well, go to the ER, and the ER said, no, don't go to the ER because unless you're really, really sick, we want you to stay away. And at some point they're going to say, start coming back. And how do you flip that switch? And I had a conversation yesterday with our friend Chuck Peck, and he's a rheumatologist. That's his profession. And I mistakenly, I hit a nerve because I said, I know orthopods whose income is just plummeting because they can't get staffed OR time because of all the crisis patients, if you will, that are in. And he sort of lashed out at me about these poor orthopods. And he's not feeling sorry for him. But the point is, let's feel sorry for the hospital because the hospitals make a lot of money on those surgeries. So that's just, we've just got to do a better job, and we'll have to. So let's move now to the solutions part of this webinar, and talk about how we stabilize and approach this. So Ben, you're our ninja, black belt ninja, Baldrige expert. So give these people some hope. How do we start?
Yeah, I'm happy to do that, and I hope all the listeners can see this screen. So the Baldrige approach, which has 7 different categories, fits nicely into the concept of an organizational hierarchy of needs. So when you're working to stabilize operations or revenue, you really want to start from a position of balance and alignment, right? So category 1 in Baldrige is really about making sure that you have a compelling shared vision. In other words, what did we learn from this pandemic, and what are we going to do different? And then encourage persistent learning around that. So it's leadership available and there at the front line and learning and participating with the team. Strategy then is, how do we prepare for the future, which includes the goals, objectives, and the key initiatives that are going to be required to align people with the purpose that you have as an organization to achieve exceptional results. Customers, you can't really overstate the importance of voice of the customer, right? There has been so much disruption in consumerism and patient access that listening to and satisfying and engaging patients and other consumers in accommodating these changing demands is going to be key for leading health systems as they respond to this crisis. Number 4 is measurement, analysis, and knowledge management, what we in the Baldrige world call MACM. And that is really leveraging your systems to ensure that you have the information and reliable data and so forth to make effective organizational decisions. And just because you have electronic systems, right, and you have business intelligence doesn't mean that you have the right information for being able to make good analytic and or prospective decisions. So that's something that organizations will want to take a look at. On the workforce, it's engaging all members of the workforce. You talked earlier, Roger, about how there's been a lot of cultural disruptions and anger and frustration, and it's understandable, right, during a crisis, particularly an extended pandemic like we've had. So being able to engage all the members of the workforce to ensure that roles and responsibilities are clear, they're empowered, they're supported in the discharge of their duties to the benefit of the patient, consumer, and organization. And then finally, operations, which we're going to get into more, is how do we do it differently now, right? How do we do it as we're moving away from an acute care model into a more value-based model? How do we manage the ins and outs with our clinically integrated network and our ACOs, et cetera? So how do we design, manage, improve, and innovate all the different healthcare services and work processes to improve operational effectiveness and deliver values and so on? So this balanced approach is obviously required. There's no silver bullet. And an organizational hierarchy of needs is kind of a good way to think about it, right, as organizations start tackling these challenges.
Ben, I think too, if we take these 6 points, I just encourage our leaders as they work with their teams, view this as a checklist. Go down the checklist, say, what are we doing with regard to leadership? What's our strategy? Are we appropriately addressing our customers, listening to them, et cetera? So it's a great checklist. Thank you. Good slide.
So I would just continue the conversation. We talked a little bit about this earlier, Roger. The key to being able to solve this problem is leaders have to optimize the capability and performance of the people, process, and technology, right? That's what they've got. And from the standpoint of that, if you look at it as an equation, the inputs are the people you have, your existing staff, your contract staff, your providers, et cetera, and then the technology platforms that you have, whatever your EHR is and whatever other technologies that you have. Those are inputs. What you're trying to accomplish is the metrics that matter on your strategic priorities. We talked about, for example, observed to expected ratios on a per patient basis, margin, quality standards, safety standards, all that kind of stuff, reduction of avoidable readmissions. And your process then is that link, right, between your inputs and your outcomes that you could look at and say, what's working, what's not working. And the general stages of performance improvement are you have to stabilize first. I think everyone would agree that there are many parts of our healthcare delivery model right now that are unstable, even shaky, right, in terms of access. I mean, what Darren was just talking about with his dad waiting 17 days to get over for an ablation from the hospital he's at to a high level, medical center, academic medical center is a good indication of that. So stabilizing is the start. Then you want to optimize flow. And for those of us that are in Lean and Six Sigma, you actually want to progress to pull. Pull is the concept where you have demand up front and the people downstream are ready for it. So they ask you for it. This would be like a nursing unit say, hey, we got capacity, we'll take your patient out of the ED. That's a pull concept, as opposed to everything being pushed, right? And there's resistance and friction and so forth all the way through the system. So you want to be able to get optimized to flow and actually progress to pull. And then you have to stay on top of that with continuously improving. What are my processes? Where are the upper and lower control limits? If there is variance on that, how do I intervene? Who's intervening? How do we make that systematized? How do we take a learning from a department that's doing well and be able to make that, a learning or a transition across the system? Roger, you know this space well, but those are the ingredients for this transformational effort.
Absolutely. Ben, if I could just share one quick anecdote. I was just talking yesterday to a young nurse friend of mine. She works in postpartum in a very good system, but she got notification that she had been exposed by another colleague to COVID. And so she was instructed to stay home, call this number, call a hotline. It wasn't really hot, it was really a cold line, but call this hotline and get instructions before she reported back to work. It was 47 hours until they responded. She called, left a message. They said, we'll get back to you. 47 hours. And she's going, they tell me I can't work. I don't know who's taking care of patients. But so we're compounding because our processes are broken. We're
Right.
compounding our problems.
That's exactly right. And these are the kinds of things that quick fixes don't work. This isn't the stuff you stick a Band-Aid on, right?
Yeah.
You have to go inside the wound, assess the epithelial tissue. Sorry, using the clinician perspective, but it's like you have to be able to debride this thing to be able to make sure that healing is on its way and that you've got the right path. So yeah. Darren, were you going to jump in on that? I thought I started.
No, I echo everything you said.
So to tee this up, Darren, I think one of the things that we had been talking about, you and Roger and Chuck and I, was if there's an example of challenge in today's world, it's this capacity issue, right? We've had different messages that we've talked to the market about, like, you can come in, nope, you can't come in. You only come in if COVID, but if you have an elective, don't do that, right? And now we want them in. And then, the competition in our catchment areas hasn't gone away just because of COVID, right? And now there's been mergers and acquisitions and expansion of footprints and all that kind of stuff. So capacity becomes a real issue. And we talked a little bit about, if you just take the acute care model mode and you accept all incoming, and really your decision to say yes or no is based on a staff bed transaction, it's too late.
Right.
So talk to us a little bit about that based on the experiences you're having on the front line.
No, absolutely. And I think this experience not only comes from being on the front line, but in my work in consulting with about and nearly 900 hospitals across the country, and seeing what everyone from a small specialty hospital to a large multi-state healthcare institution are dealing with. And again, to your point, those that are acquiring and growing and trying to grasp and grapple with these issues every day. Lest we take a look at this whole thing and I think become overwhelmed at the scope of trying to boil the ocean, that there's so much going on. I think there are some specific areas that we can focus on that have high yield, that have low barrier to entry of getting up and going, and addressing some very tangible and material issues that we're facing. Because I think every leader, as they look at a solution that they want to employ, an initiative that they want to move forward with, Would love to see that there are very definable goals in that initiative. Would love to see that there's very clear visibility into the operations and how that initiative is going to roll out. And then ultimately, there are good metrics where they can see, hey, have we been successful or not, or somewhere in between. And so, as we look at hospitals now or healthcare systems that are trying to balance or adapt to demand based on the supply of resources that they have. And I tend to shy away from the word just capacity, because oftentimes it truly is resources on many levels. Do we have nurses? Do we have subspecialists? Do we have a neurologist on staff to take care of our stroke? Are they off in having COVID and can't come in at that particular time? So this idea of access and orchestration, and Ben, you've used that term several times here, is a key starting area that meets all of these criteria. It's something that's needed. It's beneficial for hospital systems. It's beneficial across the healthcare organization to create and utilize, the resources that are available within the organization. As we look at, for example, demand coming in from the various locations through an ER. I just spoke to a major academic center where 27% of their admissions come as interfacility transfers from other hospitals, or scheduled admissions coming out of the PACU. So now you have all of this demand, and where are your resources to be able to leverage that? Is it in one hospital? Is it across multiple hospitals? How do you stage those that care? How do you accept those 27% transfers that come in, get the procedures and things done that are necessary at that location where they're transferred to, and then transfer them back to your other hospital where costs of care are lower and the patient is closer to home, within your own organization or in partnership with the transferring referring facilities that are sending those patients in. As we look at an access and orchestration strategy, it oftentimes includes what we call an access and orchestration center, oftentimes referred to as a command center or an access center. Sometimes starts as a transfer center or capacity management. And these are oftentimes already exist in organizations that are being completely underutilized for their benefit within the organization. As you look at the right side of the screen here with transfers and enabling capacity and throughput and even discharge coordination, as we look at leveraging that business unit, it's often a place where we start to what you previously mentioned is looking at people, process, and technology, and can we align that all together to get a bigger bang for the buck and better utilization of resources across the institution. A couple of key examples. An ER doctor that's sitting in her ER has a patient in there. They don't have a bed at her hospital. So she starts calling other hospitals to try and get that patient placed somewhere else. And I've heard of ER doctors, and this is not an exaggeration, talking about the 40 different hospitals that they contacted to try and get that patient placed, or as few as only 15 hospitals that they had to contact. Well, that's 10 levels below their pay grade. There's a patient that's waiting for their care that's taking up another bed. There are people demanding their time, so it's disjointed. An access and orchestration strategy, a center that could take care of that for them, take that load off and get it done much more quickly, is a key example. Assign that to them. Or like in the case of my father, finding the right endpoint location for them to be transferred to. In the case of a multi-hospital system, being able to load balance those patients and not leak them out and lose opportunities. And right now we think of our hospitals being completely filled, but I guarantee you that it's your large hospitals are full, but some of your smaller hospitals still have capacity, but you're paying those nurses to take care of empty beds. Let's get the patients moved around to the appropriate locations using that access and orchestration strategy as the way of managing all that. And two other just quick examples. The use of teleconsultation and telehealth, one provider facing, one patient facing. We're utilizing it more and more, as Roger said, 25, 38% across different areas of the organization. But having an access and orchestration strategy that coordinates all of that so it doesn't become a disjointed process is another area of improvement. And then last but not least, Ben, you mentioned this, using things like multidisciplinary rounds, moving patients through, getting them teed up to where they can then decompress the organization and get patients back out again, which of course the patients want too. They want to get home. They want to get to their rehab. They want to move forward to the next stage of care. So your access and orchestration strategy not only includes bringing people in and then getting them out the door, but it's moving them through in coordination with that final step of discharge, whether that's getting them to a skilled nursing facility and having that participation to offload some of the burden with case management so they can get those patients placed a day early or even 6 hours earlier into their skilled nursing facility, thus freeing up a bed, freeing up the PACU, freeing up the ED, and it all cascades downstream, as you mentioned, in a great pull model.
Yeah, that's great. Well, Roger, I know we're getting close on time, but maybe I could spend just a little bit of time on some, what kind of results can health systems expect if they're doing this kind of a thing as a anticipation of the post-pandemic future model. So I can just unpack this kind of quickly. What this is reflecting for those of you who are looking at the screen is basically kind of a sequential step that are very common ROI priorities, but in this new, anticipatory post-pandemic world, these become particularly significant. So what Darren was already talking about is on the input side. So being able to have a very streamlined one-call access where you have on-call providers with service level agreements, and being able to combine that with an overarching enterprise view of all of your capacity, so you can direct traffic, right? You can segment and or stratify admissions and not just wait for feedback from a bed management system, is really important. We did a study with University of Utah on this, and average contribution margin for a patient coming in is about $10,800. That second step, though, what we often refer to as the black box, right? The patient throughput experience is super critical. And there's a key lever on that at the front of the patient's stay. So once they come into a bed, as soon as that care process starts, there should be a determination about what is the estimated date of discharge based on what's been approved, right? So if I have a patient coming in with congestive heart failure and a comorbidity of diabetes, and I'm approved for 4.3 days, then let's work on that, right? Let's not start working discharge at the end of the stay and move out to 6 days or whatever. And that really is a multidisciplinary rounding focus. So this kind of concurrency of being able to see all the capacity on the front and direct traffic, and then when they're in, accelerating the movement of patients through so you can get them the care they need and turn that bed to get the next patient in, which leads to number 3, that allows you to expedite getting a patient out of the bed, and it also reduces avoidable days, which is really a malady for a lot of health systems. We've run into health systems that have, thousands of excess days per annum with patients where they're not able to just get them out in the time that they're authorized for. And then there is some opportunity if you have a pre-set post-acute curated network where, and particularly if they are owned by that health system, where you can anticipate upfront that they're going to need a post-acute, make that transition all set up and streamlined so they can get in there. There is a revenue pickup opportunity there as a percent of Medicare spend per beneficiary. And then, of course, number 5 is important to all of us. Patients in particular, not to come back into a care setting for the same condition that they left with. So all of those communication and care and empowerment things that need to happen during the clinical stay to be able to essentially avoid that. And then essentially ensuring that all of this is done in a friction-free, high consumer experience model is kind of what the future looks like. And the outcomes would be, again, like it says up here, OE ratios less than 1, hit Medicare break even. In every single step of the way, you're looking for where there are obstacles and how can we optimize performance.
Great. Thank you, Ben. And I encourage all of you who are listening to this, if this sounds good to you, sounds like something that you'd be interested in, I encourage you to contact Ben or Darren, and they can get you hooked up for that. Let's just finish with one quick case study reference. I won't spend too much time on this. I want to get to some questions, but we did a podcast recently on an implementation strategy. This whole notion of, execution without vision doesn't work. Well, vision without execution doesn't work either. So we talked to Brian Moran about this book. And the reason that we talked to him, when I was with Trinity, I did some interim work, and I was finished my work there at Loyola Health System in Chicago as the CEO. And there was a long-standing revenue cycle problem there. I was only there for a period of about 9 months, kind of getting the place ready for the next CEO. And Ben Carter, who was the CFO of Trinity at the time, and I were strategizing and said, hey, let's see if we can do something to fix this revenue cycle problem, because it was very important to Trinity, obviously very important to Loyola. And I had just read this book. This is the field guide, but the 12-week year by Brian Moran. And I can't even tell you where I picked it up, but the title sucked me in. It really hooked me, because I'm always trying to look for hacks and stuff like that. But basically, it compresses the year into 12 weeks. And I love the subtitle, Get More Done in 12 Weeks Than Others Do in 12 Months. So I was totally bought in, read the book, gave the book to Dan Isaacson, who was the VP of Finance at the time, and assigned with the responsibility. Ben and I came up with this idea of creating a FEMA-style command center at Loyola to see if we could solve this problem. So basically, we had a daily meeting every day for 30 minutes, 11:30 to 12 every morning. And we had everybody around the table who was a decision maker, had the authority to make decisions if with anything relating to revenue cycle. And they tried for years to solve this problem. They couldn't do it. And we were able to solve it using this technique, using this notion of compressing and accountability. And it was, you got to hear it from Dan Isaacson's mouth. He then became the CFO of Loyola, and Trinity chose him to be he's their current CFO. Ben Carter got promoted to the COO, and now Dan Isaacson is the CFO of Trinity Health. And he points back to this and said, we learned really how to make a difference and implement. And so I encourage you to go back and check out the Leader Dialogue podcast, where we interview Brian Moran and Dan Isaacson. So I'm going to quit there and move on to just these takeaways. Important to remind ourselves of these takeaways. Avoid the trap of annualized thinking. That's the 12-week year. Don't think that you've got 12 months. No, you don't have that much time. Get uncomfortable now, as we said before. Stop being miserable. Let's get uncomfortable in a good way. Financial stewardship. Be ready. Get your organization ready to function at Medicare break even or less. And then, as we've talked about, Darren especially, physician and employee engagement. We've really unnecessarily and inadvertently, we've alienated ourselves from some people, and people are feeling less and less engaged. And we've got to try and win that back. You earn it. It's a slow but deliberate process. And then ensure a high quality and safe patient experience. We've got to win back the loyalty of our patients and say, when we're ready for business, come on back. Maybe even say, I'm sorry, but we really do want to listen and take care of your needs. So those are some quick takeaways from what we've been talking about today. And want to thank you. We just have a couple minutes. Do we have any questions, Al, that we can maybe quickly address in the last 5 minutes?
Yeah, we've gotten a number of questions in, Roger, and I'm going to throw the first one at the team right now. And that is, how would you recommend breaking the cycle of annualized thinking?
Well, I'm going to jump in on that, and maybe Darren and Ben, you could join me. But just given the experience that we had with the 12-week year, that all of us, we have budget cycles. We close the month, and oftentimes by the time we close the previous month, we're well into the next month, and it's hard to make decisions. And so, yeah, that's a problem. But the way that we break that cycle, I believe, is to identify the problem that we're going after, be really clear, really specific, and say what's broken, what needs to be fixed, and then assign the team, build a team around that who has the authority, the decision-making authority to fix it. So there's no finger pointing, no blame, shame, nothing like that, but we are going to fix this. And if we don't have the authority among us, we got to get the person in the room around the table with us who does, and then set a very short time frame, because sometimes the solutions, just you got to listen to the podcast. Sometimes the solutions are not complex; they're incredibly, embarrassingly simple, and that's just a great way. Start with a problem, get the decision makers who can fix it, and give them a short time frame.
Any other comments from Ben or Darren on that?
I agree with Roger on that. I don't think I have anything to add. That was well stated.
Yeah, agree as well. And keeping the scope narrow and really focused is just always key. And so, no, great words of wisdom from Roger.
Thanks.
Always. Well, here's another question for you then. Given the current and future challenges, how can leaders build focus and disciplined thinking into their operational execution?
So, Al, I think I can probably tackle that one. It's interesting when you're talking about teams and process improvement, you have to have an outlet for them to express what they're seeing. In other words, you need to get their input and engagement. Patrick Lencioni writes a book about the 5 dysfunctions of a team, which we've translated into a flywheel. And the first step there is honest, robust dialogue and knowledge exchange. It's important for people that have been on the front line and are in burnout to be able to say, look, this is what's really happening, and to be listened to. And the whole goal of that step is to achieve alignment on what the problems are, right? And then, and only then, do you ask for commitment. And commitment is not agreement or consensus, it's commitment. So basically what you're saying is, I've heard you, we understand, and now, based on what we're trying to accomplish as an organization, can we get to commitment on this? And these are not macro conversations. These are micro conversations with different areas of the hospital that you're trying to work on improving your care. So you're moving from honest, robust dialogue as step 1 in a flywheel to step 2, which is commitment. Commitment then translates into execution, right? Being able to then translate that into specific actions in a specific timeline with a cadence that's associated with that. You're deploying your processes there, where you're looking at upper and lower control limits and all that sort of thing. That's really in step 3 where that comes into play, like we've been talking about. Step 4 is monitoring results based upon those metrics that matter. And that is also then where trust comes, because when teams start to understand that they're being listened to, you're asking for their commitment, and it has value to them because it's related to their work and their accountable actions that are driving results, it builds trust, and it also drives customer loyalty. And those two then are a setup for ongoing flywheel actions in terms of step 1, where you're doing honest, robust dialogue. So given the current and future challenges, I would say leaders can build focus and discipline thinking into their operational execution, probably with that process as well as any out.
Ben, I'm going to agree with you, and I know we're pretty much out of time, but I just appreciate what you said there about the open and honest dialogue among the organizations, bringing everybody to the table and really, really understanding what the goal is and making sure that everybody's on the same page. Absolutely key, and operationalizes any initiative just in the right way from the get-go. So thanks for sharing that.
Life's too short to have a lack of clarity keep us from accomplishing what we need to do.
Yeah, for sure.
You guys want to try and tackle one more quick question?
Sure.
Certainly.
Okay, got the last one here would be, how would you determine what you should stop doing?
Ooh, great question. Again, back to that quote, most people would rather be miserable than uncomfortable. It's uncomfortable to stop doing things. We get really attached to things, or we get maybe accustomed to it as well. And it's a little bit risky to stop doing some things, but I would say this comes from getting people together, just like our last question, honest, robust dialogue, and get people to agree. What is low priority? What is low what is low impact, or low return? What are these low return items? And give people some margin back, some capacity back. But it's honest and robust dialogue, and then everybody agreeing and okay, let's do it.
One thing I throw out there with respect to stopping doing things is this is where data can really come into play. And as you look at processes, especially, for example, as we look at access and orchestration, if we're asking the same question over and over again and getting the same answer over and over again, we can automate that process. And so we can stop taking people's time up to answer the question that we always get yes to, or ask the question that we always get a no to. So if we can get true automation in areas where that will take steps out of people's day, and clarify processes, using, for example, getting to a yes decision about bringing a patient in. If we're talking to 5 different people right now, we can talk to just one. Let's streamline that. And so I love looking for opportunities there where how can we stop doing things that are redundant and stop doing things that are involving people that don't need to be involved, but will get involved later anyway because they always do. Then we've got golden opportunities there, and it should be driven by data.
Yeah, I think those tech-enabled process optimization is really a great opportunity for health systems.
Well, outstanding, guys. Thank you so much. Roger, Darren, and Ben, that was truly a timely, engaging, and insightful presentation today. As a reminder to everyone out there, the Institute has a number of certification courses that are available online, and they are self-paced, including Lean Six Sigma, project management, diversity, equity, inclusion, and much more. To learn more about these courses, please visit the Institute website at baldrigeinstitute.org. Thanks to everyone for attending today. As a reminder, the recorded version of today's presentation and slides will be available on the Institute website early next week. And once again, thanks to all of our sponsors, especially the members of the Mac Baldrige Society, who are the trustees for the Institute for Performance Excellence. It is their generous support that makes presentations like today's possible. Please be safe, everyone, and have a great day.